Welcome to part 2 of your afib lecture. In this part I'm going to introduce you to abnormal conduction or arrhythmias. We're briefly going to touch on the two broad categories of arrhythmias, and then we'll talk about automaticity versus re-entry arrhythmias. To start off, we can broadly describe arrhythmias as being either supraventricular or ventricular, where supraventricular arrhythmias are those that occur in the atria, and ventricular arrhythmias are those that occur in the legs. Wait, that's not right. Ventricular arrhythmias are arrhythmias that occur in the ventricles. That makes more sense. Supraventricular arrhythmias are going to include afib and aflutter, paroxysmal supraventricular tachycardia, or PSVT for short, atrial tachycardia, sinus tachycardia, and AV nodal reentry tachycardia, or AVNRT for short. From a terminology standpoint, it's important to point out that the term SVT is a pretty non-specific term. It basically just describes a tachycardia that originates in the atria. This means that fast AFib is technically SVT. So you may, in clinical practice, hear that term thrown around a little bit, where a patient is going to present in SVT. A more technical term for what they're referring to typically is PSVT, or paroxysmal supraventricular tachycardia. Ventricular arrhythmias can include premature ventricular contractions, or PVCs, ventricular tachycardia, ventricular fibrillation, or torsades de Pointes, which is a polymorphic VTAC. And for the purpose of this lecture, though, we're going to focus primarily on AFib. And now that we've covered the terminology to describe where the arrhythmia originates, now let's talk about two different mechanisms of propagation, primarily re-entry arrhythmias and automaticity arrhythmias. If you remember all the way back to part 1, automaticity is the ability for the cell to spontaneously initiate an impulse, and it's something that happens in the pacemaker cells of the heart. So an automaticity arrhythmia is one that originates from the pacemaker cells and can include tachycardia and bradycardia. Tachycardia is commonly caused by an increase in automaticity within the pacemaker cells below the SA node. This increase in automaticity is going to generate additive impulses, which is going to cause the heart rate to gradually rise. Remember that the slope of phase 4 of your action potential determines the automaticity of the cell. So a tachycardia due to enhanced automaticity is going to be associated with a steeper phase 4, which is going to lead to more rapid depolarization and a subsequent rise in heart rate. Now, bradycardia can also be caused by altered automaticity, and this occurs when the SA node experiences a decrease in automaticity. Remember that the AV junctional tissue and Purkinje fibers also have pacemaker cells, so if the rate of SA firing is reduced enough, you could experience an escape rhythm where a compensatory beat is going to be generated by one of these lower pacemaker sites. A re-entry arrhythmia is going to occur when you have an error in conduction pathways, and it requires two functional pathways that differ in their speed and refractory period. Normally, conduction is going to happen along a single pathway, so re-entry can't occur. So let's think of conduction as a racetrack with two possible routes. So the top route here has a lot of curves and bends, and it's going to be a pretty slow pathway. The bottom route's a nice, fast straightaway, but it has a longer refractory period. So in the normal conduction pathway, you're going to have a group of race cars that's going to split, and half are going to take the slow pathway, and half are going to take this fast pathway. So the cars, or the impulses that are taking the fast route, are going to get to the end of the straightaway faster. They're going to cross the finish line, and they're going to trigger a beat. And when that happens, these impulses that are in the slow pathway, they're going to realize they've been beaten, and they're just going to dissipate and move on their own. So this signal isn't going to make it all the way through that slow pathway, and the fast pathway is going to be responsible for your heartbeat. But what can happen if you have an ectopic impulse? So let's just say, for example, that the fast pathway has a refractory period of 1 second. It's not an accurate time frame necessarily, but just for the sake of example, let's say it's a 1 second refractory period. So a normal beat is going to be generated maybe once a second here in this case. But what happens if an ectopic impulse is generated at the half-second mark? Well, those cars are going to move in here, and the fast pathway is closed. But the slow pathway with the short refractory period is going to be open. So they're going to drive their way down this slow refractory period. And when they get there, half the cars are going to move and cross the finish line and trigger a beat. The other half decide they want to keep racing, so they go backwards along this fast pathway, kind of like a victory lap in reverse. So they're going to come here, they're going to go back down the slow pathway again. And when they get here, half are going to come across the finish line and half are going to go back. And this process just continues and continues and continues. So this is considered a re-entry arrhythmia. An example of this is paroxysmal SVT or PSVT. Now this can consist of a single re-entry loop. And you can break this by giving adenosine, which will help to kill that ectopic impulse, or electrical shock or electrical cardioversion that will help to break that also. It'll basically close down the slow pathway, let the fast pathway reopen, and the impulses will be able to travel like they're supposed to. So they won't be able to go back up here, and the slow pathway won't be able to reach the finish line before the fast does. So it kind of resets it, and the normal impulses are generated again. The normal beat is generated again, and that arrhythmia is broken. With AFib, you can have a lot of these re-entry problems, so they're called re-entry wavelets. So it's believed that there are many re-entry wavelets that are responsible for AFib, which is why adenosine isn't going to work very well to break AFib, because it can't hit all these re-entry pathways. One difference you want to keep in mind between automaticity and re-entry arrhythmias is that the heart rate is going to gradually increase and decrease with automatic arrhythmias. So for example, if you go exercise hard, your heart rate's going to gradually increase and then it's going to gradually decrease again. Re-entry arrhythmias, on the other hand, are marked by sudden increases in heart rate. So if you have a patient with fast AFib or AFib with RVR, rapid ventricular response, which essentially means the same thing, you may see their rate change from 110 to 175 to 150 in just a matter of a few seconds. These re-entry arrhythmias generally respond well to electrical shock or adenosine, although again adenosine is not going to help to fix rapid AFib because of the large number of re-entry wavelets. It's just going to slow it down for a few seconds. Again, just to reiterate, shocking a re-entry arrhythmia basically zaps the cars trying to go the wrong direction, and it knocks them off the track, and it allows the fast straightaway to reopen to traffic moving in the right direction, and this breaks the re-entry loop. So this brings us to the end of part 2, pretty short video on supraventricular and ventricular arrhythmias and automaticity versus re-entry arrhythmias. Next up is part 3, and we'll get into the nitty-gritty of AFib.